Good afternoon, dear students.
Yes,
Yes,
ma'am.
ma'am.
Yes, okay. We will continue with the same.
Yes, ma'am.
Okay, okay. Please kindly mute your devices. Thank you. We will continue to again continue learning with the F20 with the schizophrenia. Yesterday, in the previous class, we have discussed what schizophrenia is all about and what is the ICD classification of schizophrenia, which is F20 to 29. That is the schizophrenia and other schizotypal disorders. Okay. And we have seen also yesterday what is the hypothesis between the dopamine pathway in relation with the signs or clinical features of schizophrenia. And we have seen the main neurotransmitters which influence or which is associated with schizophrenia is the dopaminergic pathway, serotonin pathway, then we have the acetylcholine pathway, the norepinephrine and the GABA. Now, the main one where the positive symptoms, the negative symptoms, the motor, the motor symptoms, okay, the psychomotor symptoms stems, and even the changes in the endocrine profile. So the main one is we have seen the mesocortical pathway, which is an mesolimbic pathway. From here, the negative symptoms, the positive symptoms stems, the emotions, the effect stems from here, right? The motivation, the reward, and all stems from here. Now, from the Nigro's stridal pathway stems all the disturbances in the the disturbances in the muscle function or the psychomotor function. Okay, and from there, any death or any degeneration related to the cells here give rise to the Parkinson's, right? Now, we have seen also another pathway which is also related with the dopaminergic pathway, which is the tuberoinfundibular, which is related with the endocrine. Now, we have seen all these signs yesterday, the features, the positive symptoms, the negative symptoms, and then we have seen Eugene Blueless A, we have seen Kurt Schneider. So basically, schizophrenic patient usually present with this slide that I'm showing you. Okay, they have speech, they have a problem with their thinking, they have problem with their perception, they have problem with their affect, they have problem with their behavior, thus and with their memory, with their motivation, right? Affect means the mood and all, right? Now and which in turn give rise to the disturbances in the social and occupational function, right? Now today we will discuss the types of schizophrenia. Now let's just list one by one. The first type is paranoid schizophrenia. The second type is disorganized schizophrenia. And a third type is catatonic schizophrenia. Fourth, undifferentiated schizophrenia. Post-schizophrenic depression. Residual schizophrenia. Simple schizophrenia and other schizophrenia. So today we will go ahead to see what are the different types of schizophrenia. Now, please try to understand when we discuss the types of schizophrenia, the patient will have these schizophrenic symptoms which we have discussed elaborately in the clinics also and also in the classes also. Like they will always have those symptoms that we have, but why are they called by the name of these types? Because they have particularly, along with those symptoms, they have particularly few things which is only with these types of the schizophrenia. Okay, so now please do not forget schizophrenic patient will have the positive symptoms or the negative symptoms. They will have the disturbances in their thought and their perception. Okay, in the effect, right? And we have seen yesterday they will have the first rank symptoms. Okay, and then they will have the thought alienations, the thought control, or they will have the passivity phenomena, those made feelings, right? These are given by Kurt Schneider. So this one, all those related to that, and they will have few particular symptoms which is related to these, and thus they are categorized with these different types of schizophrenia. Now let's see. In paranoid schizophrenia, from the name itself, paranoid is always the literal the if you can say what is the meaning by this word paranoid means suspicion. Paranoid means you always think someone is out there to harm you. Okay, like even if the people think they perceive suspiciously, they perceive that something is not right, they perceive all that. Okay, so in paranoid, now let's try to understand this picture. I've tried to search a better picture for you to understand, but I thought from the patients that we have discussed, and you have nursed and you have taken care in the clinics, and which and with this picture I think you will be able to relate and why this type is known as paranoid schizophrenia. Now let's see here. Hey, what's up? What are you doing? Wanna hang out? Can I ask you something? We should do something. That means if suppose I asked you, or somebody asked me this. Now, if I have suspicious thinking, what sort of thinking will that I may have? Like, no one likes you. They're out there to get you. My mind will tell me. Remember that passivity phenomena, that thinking, that belief, and our actions, our impulses, our volition is made or controlled by the other. Thought insertion, thought withdrawal, thought broadcasting. Remember? Okay. So basically, in my mind, if I have these, I say, no one likes me. Okay, my mind will tell me, no one likes you. They're out to get you. Okay, they aren't really your friends. They hate you. They'll steal your idea. You can't trust them. So these are the thinking or the control, and these will influence my behavior. Okay, so that means these are all suspicious paranoid thinking or belief. Okay, which controls me because I think nobody likes me. Okay, there is a saying in my mind, no one likes you. They're out to get you. They hate you. They aren't really your friends. They'll steal your ideas. You can't trust them. There's poison in the food. You know don't trust them. They will do this. Don't drink that drink. What if they add something in that drink? Okay, or don't tell. What if you tell them and then all that? Okay, now what if they hide something behind you? Right, so all these thoughts will govern my thinking and thus influence. Okay, now let's see. So paranoid schizophrenia, basically individual has feelings of being persecuted or plotted against. Remember those thinking? Since I am thinking like that, my mind tells me, so I feel like others are always there. He or she will feel that others are always there to harm them, or they always do something to harm or which is against the person. Now, so paranoid schizophrenia is characterized mainly by the presence of delusion of persecution or grandeur and auditory hallucination related to a single theme. Now, these themes of delusion, we have discussed all those themes of delusion in the when we had clinical discussion. Right now, just relate to that. Now, because I am big, because I have so much money, because I won a lottery of 1 crore. Now everybody wants to be my friends. Why? Because they want my money. Or all the family members are nice to me. because they want it, or C, they want to kill me because they want my money. So all those persecutory delusion. Now what is the grandeur delusion that I have? The grandeur delusion that I have is because I have won a lottery of 1 crore. The other grandeur delusion is because I got promotion. So my colleagues don't like me anymore. So my colleagues, they want to plot something against me. Right, now delusion of persecution in the other hand is what we have seen right now. Let's say a single theme right here. So they want to harm me, they want to poison my food, or they want to go and defame me, okay, all that. So when a person has these persecutory or delusion of grandeur and hallucination related to a single theme, so now whatever it is, if they are persecutory and they are involved with the paranoid feelings or being persecuted feelings, that is paranoid schizophrenia. Now, so what happened here? Individual will always be tense, suspicious, and guarded. So when we try to take the history and when we try to run the mental status examination, they will say, I don't know. Right? They will not tell us much. They will always look at us with a different, effect. Right? They will always be guarded. Right? And maybe argumentative. Why are they argumentative? Because they will say, why do you want to know? What is so important that you have to know? And some of them becomes hostile and some of them becomes aggressive. Okay, so often you will see tense, suspicious and guarded, maybe argumentative, hostile and aggressive. Now, paranoid schizophrenia can start late 20s or 30s, and usually it is insidious in onset. Okay, that means insidious is what? Remember when you all take the history, you see whether the incident is abruptly in onset, abrupt in onset, or slowly insidious in onset. So paranoid schizophrenia, when you see these signs and when you collect the history and when you run the mental status, when you correlate, when you analyze it, you will find that the onset is insidious, the course is progressive, and complete recovery is not possible. Okay, that is so with all those signs of schizophrenia, the one which is markedly that you will classify, that fit in the classification, is if they have suspiciousness and if they have always persecutory sorts of feelings, okay, and they are guarded and they will be argumentative, hostile, aggressive. Right, now that means the onset will be is insidious, not abrupt. The course is progressive and complete recovery is not possible. Now, how will you know what is the cause of the course or the duration? Remember, if you will recall, when you write the history, in the history of present illness or past illness, you always write there what is the onset and what is the duration. So as you write, you will see that if the course is progressive and it becomes and you will see that slowly it develops. Right, think of the thoughts, think again, disturbances in thought, in perception, in affect. Okay, do not forget those main signs of schizophrenia, and you will call it a paranoid schizophrenia only if he has persecutory thought, and then tense, suspicious, patient is guarded, all this. Okay, now next type is the disorganized schizophrenia. Now if you will refer some books will say this as the hebephrenic schizophrenia. Okay, now what is so special, or what are the criteria that makes a schizophrenic patient fit into a disorganized schizophrenia, phrenic, or or a hebephrenic schizophrenia. Now, so here the onset of the symptoms is usually before the age of 25 years. The course is commonly chronic. You will see it is very chronic. Uh, the symptoms, when we will see these symptoms, you will be able to relate. But all those old patients that we have nursed in sun care, okay, those who have taken their history and who have run the mental status examination, when you have observed them, you will be able to relate it. Okay, now, so hebephrenic schizophrenia, also known as disorganized schizophrenia, it is characterized by emotionless. You will see some patients, they will look, when you look at them, no effect, blunt effect, flat, okay, like bubble, right? Now, incongruous or silly behavior, intellectual deterioration, frequently beginning insidiously during adolescence. Now, they may be verbally incoherent and may have moods and emotions that are not appropriate to the situation. Later on, in the subsequent slide, you will see the hebephrenic, they may not have strong positive symptoms, but the negative symptoms are more. These hebephrenic patients, the positive symptoms may not be very strong. They may have had history before, but it is not so strong as that of the negative symptoms and other symptoms in the emotions and in the behavior. Okay, now let's continue. So these hebephrenic or disorganized have disorganized speech and disorganized behavior. They have marked thought disorder, incoherence and severe loosening of association. They have emotional disturbances is common, and behavior is primitive and regressive. What is primitive? Primitive are all those old Stone Age behaviors, right? Very uncivilized, right? And regressive. That means regression. Please try to correlate with the word regression. That means we go back into our primitive lifestyle, or we go back into the those prehistoric, okay, or we regress in our growth. Okay, now that is this. Now, so contact with reality is extremely poor. I told you they may not have strong positive symptoms of hallucination, but other psychotic symptoms are there. Okay, now, well, because it is a psychotic case, so definitely the contact with reality is extremely poor. Affect is flat and grossly inappropriate. If you look at them, no feelings, no emotions, anhedonia, apathy. Okay, but please mark this: silliness and giggling. They have a lot of mannerism in them. Okay, they show that very grimacing. They show that they will laugh for no reason. Okay, they will make a funny face which are not appropriate. Okay, and then sometimes they do things which are very silly. And see, I told you they have a lot of facial grimaces, bizarre mannerism, and the communication is consistently incoherent. Now, and another thing, along with that, if you look at their personal appearance, okay, usually they look very unkept, very unclean, as if they've not taken bath for years or for weeks and for days together, and their social impairment is extreme, very extreme. They have no social the social skill, right? So if you ask them when we do in a group, others may function, but their social function is very impaired. Now, so in paranoid, in the first type, paranoid, they have more of the persecutory thinking, and they have the strong positive strong symptoms of schizophrenia. That's why it is called as it is called schizophrenia. But it goes to paranoid because they have all those delusion of persecution, right? Then they have all those thoughts that someone is harming them, they are guarded, they are hostile. Okay, now when it comes to disorganized or heavy phrenic, the main thing is they are unkempt, right? They may not have hallucination, but most of them have strong negative symptoms, and they have a lot of facial grimaces, no emotion, very flat affect. And when you look at them, the minute when you run mental status examination, when you observe at them, you will see that they are very poor in their personal hygiene and or their personal appearance, and their social skill is or social adaptation is extremely impaired. Okay, so that this is disorganized schizophrenia. Now, catatonic schizophrenia, the third type. Catatonic schizophrenia is characterized by marked abnormalities in motor behavior and may be manifested in the form of stupor or excitement. Catatonic, remember, catatonic has got to do with psychomotor. Okay, marked one. If with all those signs of schizophrenia, there are also features of disturbances or changes in the psychomotor behavior and in the along with the all those made feelings, made all those, right? Now, if they have those, when motor behavior is involved, then it goes into catatonic schizophrenia, which can be either stupor or excitement. Now, what are the common catatonic behaviors? Either they will have very rigidity or stupor that lasts for hours or even days, or they may have when they have increased agitation. Okay, they become very excited or agitated. They perform strange movements here. Okay, they have erratic and extreme movement, right? And they can stay in uncomfortable position without shifting. Remember, we have seen the disturbances in the motor activity when we have learned catalepsy, posturing, flexibility, right? If you will please recall to that, you can relate to that well. And they have echolalia, which is repetition of words. Right, so they can be either stupor or they can be in the excitement. Now let's continue. Now, so when a person, when you see a patient more where the psychomotor behaviorism is involved, then along with these symptoms of schizophrenia, then you can think of catatonic schizophrenia. Okay, now let's continue. So catatonic stupor is characterized by extreme psychomotor retardation. Stupor, when there is decrease of the motor function, right? So catatonic stupor is characterized by extreme psychomotor retardation. The individual exhibit a pronounced decrease in spontaneous movement and activity. Mutism is very common and negativism may be evident. If you will recall and relate, it can be either active negativism or passive negativism. Please relate, please recall those terms. What when we do, a person do differently, or a person can when we ask to do, the person do just the opposite of what we do, right? Now that is negativism. Now let's continue. So the symptoms in the catatonic stupor is usually a syndrome. Okay, you may see this in Parkinson's. You have learned about neuro, you will be able to relate well. So it is a clinical syndrome of akinesia or mutism. Okay, now the signs may be are mutism, negativism, stupor, ambitendency, echolalia, echopraxia. We have learned all this. Echolalia, where there is echoing of words, repetition of words. Echopraxia, where they repeat whatever you do. Right. And then automatic obedience, we have posturing, we have mannerism, anything which the movement which is done repeatedly, right? And we have stereotype. The stereotype is either in the speech, either in the position, or either in the movement. Okay, recall, please relate, you can recall those classes that we had discussed in the clinics. So these are the signs. Now, so akinesia, usually they have, that means the akinesia is a term for the loss of ability to move your muscles voluntarily. Okay, so this is a picture of catatonic stupor. Now let's see what is waxy flexibility. Okay, so waxy flexibility may be exhibited in catatonic schizophrenia. Okay, now this term describes a type of posturing or voluntary assumption of bizarre position in which the individual may remain for a long period and it does not harm them if they don't look tired, or it does not show that they are in a difficult position. Okay, efforts to move the individual may be met with rigid bodily resistance. If you try to change, they will resist. Okay, remember we have discussed catatonic may be stupor, or it may be the excitement. Okay, now so the other one is excitement. Now, in catatonic excitement, it is manifested by a state of extreme psychomotor agitation. Stupor is when there is no. Still, it involves the psychomotor behavior. Okay. Then, in excitement, there is increase in psychomotor movement, or there is extreme psychomotor agitation. Now, the movements are frenzied and purposeless, and usually accompanied by continuous incoherent verbalization and shouting. Now, so clients in catatonic excitement urgently require physical and medical control because of the excitement, because of the increase in the psychomotor behavior. They become very agitated. So they are often destructive and they are violent towards others, and their excitement may cause them to injure themselves or to collapse from a complete exhaustion. Because now, so how do we differentiate between catatonic stupor and catatonic excitation? So we call it a catatonic when it involves the psychomotor behavior. If they are decreased, stupor. If increase, excitement, so it goes into catatonic excitement. Now, residual schizophrenia. This diagnostic category is used when the individual has a history of at least one previous episode of schizophrenia with prominent psychotic symptoms. Okay, so it is called a residual. That means when you collect the history, he may or may not have recurrent episode, but a client will give to you the history that at least one episode is there and very marked psychotic symptoms. Okay, delusion, hallucination, okay, imbalance or loosening of association, okay, all those, right? So prominence that, and but currently it is not there. That's why it is called residual. Pehle tha, they had all this, right? All these prominently, but now they may have only a few of the negative symptoms, right? Or some of those mild symptoms of schizophrenia. That's why it is called a residual schizophrenia. Now, so residual schizophrenia occurs in an individual who has a chronic form of the disease and is a stage that follows an acute episode. I told you, remember? Initially, they will go with very acute episode marked prominent delusion, hallucination, incoherence, bizarre behavior, and violence, right? And then after that, when they calm down, right, and they go towards the towards more of the other symptoms, but not the acute psychotic symptoms, so that they categorize that into a residual schizophrenia. Now, so in residual schizophrenia, there is continuing evidence of illness. You understand? Other signs of schizophrenia will still be there. But if you want to see in them like the prominent psychotic symptoms, it may not be there. It will not be there. But we call it a residual because one full episode with strong symptoms is there. Okay, now, so residual symptoms may include social isolation, eccentric behavior, impairment in personal hygiene and grooming. They have features of impairment with the effect, which is blunted or inappropriate effect. When it comes to speech, the client may have poverty of speech. And when it comes to their thoughts, they have illogical thinking. And when it comes to their affect, they have a lot of apathy. Okay, so that means now all these match the negative symptoms. So they still have those very prominent, but one episode of strong acute psychotic symptoms with strong positive symptoms is there. That is a residual schizophrenia. Now, undifferentiated schizophrenia. Now, in undifferentiated, from the name itself, it does not meet any criteria of the subtype. Yeah, they are schizophrenia, but they don't meet any of them. So, or they may meet the criteria for more than one subtype. They have this also, they have this also, they have this also. So we cannot differentiate them into any either paranoid or catatonic or residual. Okay, so they classify them into undifferentiated. Now let's see the behavior. So the behavior is clearly psychotic, and there is evidence of delusion, hallucination, incoherence, and bizarre behavior. Okay, now that is, but you could not place anything exactly into the other type. Now, post-schizophrenic depression. Now, there will be increased risk for suicide. Now, why depression is involved? If you will recall, the dopaminergic pathway and the serotonin pathway are very closely related. So if there is disturbances, definitely in the serotonin pathway also it does disturb it, right? And then the mate effect, the mate thought alienation is there, right? So there will be increased risk for suicide. Depressive features occur due to the side effects of antipsychotic. Regaining insight after recovery are some of the symptoms. Now, in this one, in post-schizophrenic depression, what are the side effects of antipsychotics? Remember, the antipsychotics will work in the dopaminergic pathway and in the neurotransmitters involved. Okay, remember, if there are positive symptoms, overexcitation, so you calm down. If it is hypoactivation in the neurotransmitter of the mesocortical, then you increase, okay, right? So because of that, it do lead to the symptoms of depression, right? So that is why it is called post-schizophrenic depression. Now, simple schizophrenia. Simple schizophrenia, it is characterized by early onset, insidious, and progressive in nature, and negative symptoms are present. The symptoms include vague hypochondrial features, living shabbily, and wandering aimlessly. Wandering behavior, most of you have presented with your cases where patients have wandering behavior. They roam, they walk, they wander, okay, aimlessly. Delusion and hallucination are usually absent, but the negative symptoms are present, and the prognosis is poor. Okay, simple schizophrenia. Now, what schizophrenia is? Pseudoneurotic schizophrenia. Neurotic, that means reality orientation is there, right? But it has got to do more with anxiety. F40. Okay, it was described by Hawken Clayton. The features are free floating anxiety, paneurosis, and pansexuality. Then the other schizophrenia is schizophreniform disorder. Duration is less than 6 months and with better prognosis. Other schizophrenia, we still have honoroid schizophrenia. The honoroid means dream. Okay, it is an actuarial onset where they have a little bit of delirium features. Remember, recall delirium, they may have delirious features, which is clouding of consciousness, disorientation, and they have dreamlike states and perceptual disturbances with rapid shifting. Now, Van Gogh syndrome is there will be dramatic self-mutilation. This always they often ask what is Van Gogh syndrome. Okay, they have dramatic self-mutilation. Or they are lost in their own fantasy world. They are more drawn with some of the Van Gogh's patients with Van Gogh syndrome. They are good into art. They dramatize themselves, but they have self-mutilation. Now, late schizophrenia occurs in late life, common in women. Delusion of persecution with fantastic intents like being raped or strangers entering their rooms and interfering. Okay, hallucinations are present. Then Rove schizophrenia occurs in the presence of MR and behavioral disturbances are common. Now, what are the diagnostic criteria then? Okay. According to ICD-10, for the diagnosis of schizophrenia, a minimum of one clear symptom belonging to any one of the groups referred to as A to D, or symptoms from the least two of the groups referred to E and H should have been clearly present for most of the time during a period of 1 month or more. If duration is less than 1 month, diagnosis of schizophrenia like psychotic disorder should be made. Now, if these psychotic symptoms are present, but they have not been there for more than 1 month, less than 1 month, we can only classify them or diagnose them or make the diagnostic formulation as psychotic symptoms. Now what are these? Now, let's see. If one clear symptom belonging from A to D, okay, or two from E to H, A to D. Now, let's see what are A to D. A, thought echo, thought insertion, withdrawal, or thought broadcasting. B, delusion of control, influence of passivity, clearly referred to the body or limb movements or specific thoughts, actions or sensation, delusional perception. C, hallucinatory voices giving a running commentary on the patient's behavior, or discussing the patients among themselves, or other types of hallucinatory voices coming from some part of the body. And D, persistent delusion of other kinds that are culturally inappropriate and completely impossible, such as religious or political identity, or superhuman powers and abilities. So, anyone from here and two from E, okay, from the E. Persistent hallucination in any modality when accompanied either by fleeting or half-formed delusion without clear effective content or by persistent overvalued ideas or when occurring every day for weeks or months. And F, breaks or interpolation in the train of thought resulting in incoherence or irrelevant speech or neologism. G, catatonic behaviors such as excitement, posturing, or flexibility, negativism, mutism, and stupor. H, negative symptoms. It must be clear that these are not due to depression or medication. So, as significant and consistent change in the overall quality of some aspect of personal behavior manifests as loss of interest, aimlessly idleness, and social withdrawal. Okay, so this one, they say that two from E to R, or one main thing from there. Now, all these should persist for 1 month. Then we meet the criteria of F20 schizophrenia. But if it is less than 1 month, then we can only diagnose them as psychotic symptoms. Now, what is persistent delusional disorder? Delusional disorder, persistent delusional disorder. We have seen all those various delusions. We have discussed on them also. So, any group of disorders characterized by the development of a single delusion or of a set of related delusions, which are usually persistent and sometimes lifelong. They are often either persecutory, hypochondriacal, or grandiose in nature. Okay, now what is the schizotypal disorder? Schizotypal, it is a disorder that is characterized by eccentric behavior and anomalies of thinking, an effect which resembles those seen in schizophrenia. It resembles, but they do not have those strong features or the characteristics that marks them to be schizophrenia. So, though no definite and characteristic schizophrenic anomalies have occurred at any stage, you understand? So they have the that means they have this withdrawn to self. They have those lost and very odd. They don't like to talk much. They have blunt affect. Okay, all those they have, but they do not have any of the characteristics of schizophrenia. That's why we call it schizotypal disorder. Now, acute and transient psychotic disorder. This acute in onset as a defining feature of the whole group. They are presence of typical syndrome, presence of associated acute stress. Okay, that is acute and transient psychotic disorder. Then schizoaffective disorder. Schizoaffective. Affective means affect, right? The affect. These are episodic disorders in which both affective and schizophrenic symptoms are prominent within the same episode of the illness, preferably simultaneously, but at least within a few days of each other. Okay. Now, we will do the treatment in the next class, because in treatment we will be learning the therapies, most of the therapies that we have already discussed. We will discuss in detail antipsychotic and their side effects and how do we deal with that. That we will be doing in the next class. So, today we have discussed the F20 types, the paranoid schizophrenia. We have disorganized, remember, paranoid, those who have suspicious feelings, right? Then we have disorganized, also known as hebephrenic. Now, for this, they call it the, now let's see. Okay, let's just go through this and we will stop. So over here, mostly they have grimacing, they giggle, and then they are poor, kept in poor personal hygiene, okay? And social impairment is very poor. Catatonic, either stupor or excitement. This has got to do with psychomotor behavior. If it is decreased, it goes to stupor. If it's the agitation, they have excitement. So when we have waxy flexibility or posturing, along with the other symptoms or features of schizophrenia, then we classify it as catatonic. Then we have the residual. That means one episode, but after that they don't have prominent psychotic symptom, right? So they term it as residual. Then undifferentiated, when you cannot differentiate or it does not meet, that means it has few features of all those and it does not meet clearly any type. So they put it in undifferentiated schizophrenia. Post-schizophrenia depression is when signs of depression develop after the features of schizophrenia. Okay? Now, simple schizophrenia, early onset, they don't have strong positive symptoms, but they have a lot of negative symptoms. Okay. So, these are the main ones, and we will be doing the treatment in the next class. Thank you, students. Have a wonderful day. Thank you.